Namaste. Welcome to the part 2 of our interesting discussion on the questions of a therapist. We have our subject expert, Dr. Himanshu Vaidya. Namaste, sir.
Namaste.
Sir, in the previous part 1, we were having a very interesting discussion on how there are different beliefs related to gender, culture, religion. How do the therapists take a stance for self and keep the healthy space between the patient and self?
Right. So we were discussing the gender part, and I had taken up the example of homosexuality.
Right.
If somebody comes in 1950s, you would have said it's a disorder to be solved. Today, in many countries, it would be a crime to say it's a disorder to be solved. So from one extreme, we have gone to the other, whereas psychoanalysis tells us that you can have both situations, a natural homosexuality and a defensive homosexuality. And a defensive homosexuality has a traumatic core to it, which has to be solved. And once done, you are still free to choose whatever orientation you want. So we don't have a prescription of orientation, but we definitely want to solve pathology if that is behind anything, not only homosexuality, even heterosexuality. Any orientation which is based on a pathology, that pathology has to be removed and the person has to be set free to make a choice free from pathology. So this is one part of the whole thing, that often the contemporary discourse, which has gone to one extreme, the woke extreme, is not actually a good scientific position.
Right, sir. So it's usually seen, even most of the experts over years and years of practice tend to have some blind spots in the therapy. It can be to do with the diagnosis, it can be to do with the comorbid conditions, it can be to do with the goal setting and the pathologies around the goal being set, or in fact, the techniques and tools as well. So how important it is to come out of this blind spot, and how do we deal with this in the therapy?
It's a very interesting question and a very difficult question, because by nature a blind spot is such that it is invisible to both the participating people. And unless you have a very good supervisor, it cannot be detected. Or it can happen that therapy goes on for many sessions. Say you have gone past 60 sessions, 75 sessions, and something comes up and you realize that this is so important, it should have been in the center long ago. How was it a blind spot for so long? Not only did it not come up, I never noticed that it has not come up. And I never had a question why it has not come up. Because by definition, the blind spot is completely blind. So it is very, very important what a blind spot is. And this is even more important in psychoanalysis, since we are focused on not only the articulated problem, which is the case in many therapies, that the client articulates the problem and that is what we are focused on, but we are essentially focused on things which are not articulated.
Absolutely.
So we are dealing with the blind spots far more than any other form of therapy. So it is very important. The question is, how would a blind spot occur and how would it get detected? It can get detected primarily out of a very simple observation of a strange absence. In psychoanalysis, we say absence often is more important than the presence. Meaning, a person has talked to you about his father, his brother, his sister, his mother, but not about his grandmother with whom he has spent most of his time. Or he has talked about grandmother, mother, sister, brother, but never of his father. The father is absent. It happens in many cases that the person talks about everyone, but one family member does not talk about much. So that absence is even more roaring. The silence is roaring. That absence is more important than the presence because it is the most heavily defended against. The more strongly something is defended against, the more likely it will be a blind spot and it will not come up in therapy. So let us say a person talks about his father, his mother, but he does not talk much about the feminine side of himself. Now, what it means is that there is identification and internalization from the father's side, also identification and internalization from the mother's side, but that identification and internalization is extremely anxiety provoking. He is not comfortable with the feminine side of him because maybe that internalization may be provoking a bisexuality, a homosexuality, or something very difficult.
Right.
Often you see a situation of a person with narcissistic father and a dependent mother. The boy internalizes the father and narcissism is in the front, but the internalization of the mother and the dependence at the back is completely repressed and defended against. So in the outer world, the person is busy living the life of an achiever, but deep inside what he really wants to be is a dependent. But that is defended against. It's an internalization, but it's an identification and internalization with the mother, which is strongly defended against. So it may happen that the person may be in therapy for 3 years and his dependence may never come up. You may never see him as a person with a strong dependent personality component in him. And it may remain completely unconscious. And this is what many times happens, that the person undergoes a long therapy. Therapy ends, but the blind spot remains a blind spot. And the person that tells you that I was in therapy for 5 years, 3 days a week, I don't know how, but it just never came up. And this happens to many. It's quite a common thing. Blind spots are quite common. Even in long-term therapy, they are quite common. So this happens, one. The second part about this discussion is, why does it happen? It happens because of 3 primary reasons. There can be more, but 3 primary reasons. One, there is a collusion between the resistance of the patient and the resistance of the therapist. What we call the resistance collusion. So there is a conspiracy unconsciously hatched by the 2 of them, not to bring up this thing in discussion. It is so anxiety provoking for both of them that both of them have a similar orientation towards some material, and therefore unconsciously both decide not to
Overlook.
quote. So both of them are comfortable with the blind spot remaining blind. So it is very discomforting for both of them. And therefore there is an unconscious collusion, creating a collusion of resistance, whereby the blind spot remains blind. There can be another reason the inexperience of the therapist. That the therapist may not notice a strange absence. That in any human being, there are certain common things which will always come up. If somebody has been with father, mother, brother, sister, how is it that the father never appears or the brother never appears in discussion? So you have grown up with XYZ, they have to come up sometime in therapy. If something is omitted, it means it's something to do with heavily defended area. What is absent is most heavily defended against. So absence is more shining than the presence. So this is one reason that the therapist may not be experienced enough to note a strange absence and bring it to the notice of the patient that it seems strange that this should be absent. It has never come up in our discussions. Second can be, it can be a one directional blind spot. That a patient comes into therapy, but something is so shameful for him. And in Indian situation, usually it is homosexuality. That he may go through the whole therapy, his anxiety, depression, and whatever he has come up for gets substantially better or even completely better. He feels okay and he goes back, he never explores that part. So that part remains one directional blind. So it's not blind to him, but he has made sure it remains blind to you. And often it is very conscious. So with regard to sexual orientation, with regard to some legal case one may be involved in, and with regard to one's finances, these are the areas where usually a one-sided blind spot is created. There is another aspect of this one-sided blind spot. At times, the therapist knows that the other person is creating a one-sided blind spot and the therapist allows it to go on. Because the therapist realizes the patient does not have the resources to deal with that discussion. And if that is interpreted or brought in, it might well be the end of the therapy. So then the question is, something is better than nothing. And the therapist decides as a judgment to not bring it up in discussion. And in future, if an opportunity comes or the patient opens up and develops safety and trust, maybe this can be broken open. But the therapist allows the patient to create a one-sided dark spot, which the patient feels is a dark spot, but actually is not a dark spot. There is an interesting thing related to it, something other, which I called a white spot.
Okay.
And this is very interesting. And this is something very unique to psychoanalysis.
All right.
That a person has problems A, B, C, D, E. In all his entire therapy, no matter how long and how many times a week, he talks about A, C, and E. He never talks about B and D. But out of B and D, B automatically gets resolved.
Okay.
It never came up in therapy, but it got healed during the process. Because what came up in therapy had some linkage to it. And because of that linkage, which we don't know, although it was a blind spot, it got healed. And therefore, I call it a white spot. It's not a dark spot, it's a white spot. It never came up in therapy, but it got healed in the duration when the therapy was on. And this is one of the reasons why it is very difficult to empirically evaluate or do a clinical evaluation of psychoanalysis just as you do a clinical evaluation of a drug, because many of the benefits are collateral. Many of the things never come up in the session, but they get healed. And the quality of life goes up by that amount. And when the person does a cost benefit analysis of psychoanalysis, that he forgets to count that benefit as a benefit. Because he feels that because it did not come up in therapy, therapy has nothing to do with it, which is not true. Many things that don't come up in therapy and yet get healed, in a majority of such cases, therapy still has something to do. It is not independent of the therapy that these things have got healed. Some of them can be independent, but not all of them. So this also leads to something which I call the white spot. What never came up in therapy but got healed during the process of therapy, seemingly independent of the therapy, but often not independent.
And I would like to name it the magical spot.
Yeah.
The unrevealed one.
True.
So another aspect as young therapists, we tend to observe that there can be this tendency to overgeneralize the application of tools which has been successful with the past clients.
True. And tools is an area which is extremely important to deal with. Unfortunately, psychotherapy as a whole and psychoanalysis in particular are extremely tool deficit areas. They are tool deficient areas. One of the reasons why this is so is because psychoanalysis evolved in a context of 5 days a week. Because Freud always used to see patients 5 days a week. Rarely it was 4 days or 3 days.
Mm-hmm.
So if you're seeing 5 days a week or even 4 days a week, it's practically every day. So even if there is no self-work to be done, it's fine. But today, when it is not possible time-wise, cost-wise, to see patients 5 days a week or 3 days a week, and by and large, we have 2 days a week, some patients even 1 day a week, then self-work as an activity becomes important. And for self-work, we need tools. So we need tools for self-work of the patients. We need tools for ourselves to be used in the therapy session. And we need tools for group therapy. And we need tools which caregivers or others can help the patient use. So we need different types of tools. Now, what you're saying is correct. Generalization of tools happens. And that has to do with 2-3 things. One is the inertia of the therapist himself. That the therapist does not want to try new tools. He does not want to take the whole pain of trying out a new tool, learning a new tool, trying out a new tool, and so on. So in his haste to see as many patients as possible and having too much on the plate otherwise in life, he tends to use what he already knows. So that is one difficulty with psychotherapists. One way out of it is continuing education. That if you are forced to attend 2 conferences per year or 2 workshops per year, and in them you learn some new tools, automatically it gets upgraded. And many countries have continuing education as a compulsory part of the licensing renewal process. That partly takes care of it. But it remains a fact that generalization of tools happens. Now, when you come into generalization of tools, there are 2 interesting aspects. One is technique development does not happen. And the therapist is fumbling with tools, with interventions. Say, for example, a therapist gets a patient, a narcissistic patient, in whom he finds it difficult to find any transference. Now, if he knows cohesion theory, he would realize that the blatant normal transferences like that of the father, the mother, the lover, they are not happening. But a very subtle self-object transference is happening. But the therapist is not trained in cohoot, so he does not know. So he doesn't even know the transference is happening. He feels no transference is happening. So he points it out to his supervisor that my problem is no transference is happening. And how can it be? Right? So then if the supervisor knows about cohoot, that this can happen, he may have the idea that self-object transferences may be happening. But because the therapist does not know about cohoot, he does not recognize that. So transference is there, but the therapist cannot recognize because of the lack of knowledge. But now the important point comes, what to do about it? Because supervisor also is not a cohesion supervisor. So the easiest for him to do is to forge a new tool all by himself and give it to the therapist and say, you try this intervention. But a better way is to ask the therapist to go to what is called a consultant supervisor. So there is a general supervisor and a consultant supervisor. A general supervisor for a long time and a consultant supervisor when something specific comes. So the general supervisor leads us to the consultant supervisor just to get guidance on this particular aspect, that if a self-object transference is happening and this is the situation, what intervention do you make? What statement do you use? And obviously the consultant supervisor has to be a cohesion, a senior cohesion who has done this many times over. So he then guides the therapist and the therapist comes up with a relevant, accurate tool. Now this process, because it does not happen most of the times, you try to generalize whatever you know. That you are in a situation where your tools are not relevant, but because you don't know anything better, your supervisor does not know anything better, all you do is you try to repurpose what you know. And that is where ineffective generalization of tools happens. This is one aspect. The second aspect is the tools across the schools. Like if you are trained as a Freudian therapist and part object transferences are coming, you don't know what to do about it. So the language that you use is completely beside the point. So one, there is a difficult and problematic generalization of tools. And second, I think very importantly, there is a wrong deployment of tools. This is also a very important aspect, that there is a wrong deployment of tools. In a Kleinian situation, you are using Freudian tools. In a cohesion situation, you are using a Kleinian tool. So with regard to tools, there are three aspects. One, there is a deficit of tools. Two, we don't know when to use which tool because our knowledge of different schools is limited. And three, we are not trained in different tools and we don't go to consultant supervisors. So these are very, very important elements with respect to tools. And one way to address this is to attend workshops on tools. That how do you make an intervention? Like, say, for example, you realize the split is open. Now, what do you do? Do you make an interpretation? Do you ask him to reflect? Do you ask him to do a visualization exercise? Do you try to bring together by bringing to his attention that he said X 2 days back about something and now he's saying minus X? And if you put together both of them, what does he think about the real object? So what do you do about the split? So this is where the tool part comes in. The training related to intervention and interpretation comes in, and the training related to tools and exercises comes in. And because it is not there, what your observation you have made is very true, that there is a overgeneralization, wrong deployment, and on the whole, deficient and ineffective use of tools in therapy.
So it's very puzzling part of the therapy, that is the stuckness of the pathology. Sometimes the clients, due to lack of or a poor ego strength, they do not allow the therapist to go on with the actual pathology, and they keep it, the surrounding effects, and then they eject out of therapy. Then after 2-3 years, they're back again, and no amount of psychoeducation or counseling or therapy itself allow them to be open with the thing. So there is this constant stuckness of pathology with certain clients. How do we deal with that? It's a big dilemma for the therapist.
Yeah, it is. It is for all of us. We'll always have patients where we are stuck and things just don't move. And what appears at the first sight as stuckness actually is three different things. There can be a stuckness where things are just not moving beyond a point, that things were okay, everything was okay, sessions were going on, improvement was happening, and after some time it just got stuck. This kind of stuckness can be, not always, but can be and mostly is related to a frozen anger, a very solid frozen anger that is now coming to the surface. It may be towards some person, mostly the parents or some authority figure, or somebody who has deeply disappointed you emotionally. Or it may be related to you transferentially. Or it may be related to you because of some reality reason. But usually it is transferential. So that stuckness is because of a frozen anger. And if the person has the capacity to really deal with that anger, and we can bring it in discussion, that this is what it is, that there is a frozen anger and you are paying a heavy cost of all the suffering you are going through because this is not melting and flowing out. So can you and I together take a closer look at this and allow it to flow out so you don't have to suffer? So you have to be on the side of the person, and both of you have to be against this anger. If you say something on this, that you are holding on to your anger and something of that sort, and if it is not rightly worded, what will happen is you will be fighting the person instead of the anger. And then it becomes an ego clash. So you have to be very precise in communication, that You are with the person and both of you are against this anger. This is one, what it is and how to address it. Second stuckness can be because of an ego clash. That instead of attacking the pathology, by mistake you have attacked the person and his ego is hurt, and now it is your ego versus his ego, and he will not allow you to heal him because he won't be able to see you victorious. So because of his ego tussle, he has to make sure that you fail. Doesn't matter what cost he pays, but he will make sure that you fail. So you have got into an ego tussle with somebody unknowingly. Third is, you may be dealing with a narcissist and he won't allow you to give him insights. He has to have all the insights from inside. So nothing outside can come for him which can be wiser than him and which can heal him. So his narcissism will not allow you to heal him. Everything has to appear to him as though it is coming from inside of him. So that can also lead to the stuckness. Then there is a stalemate, where you have reached a situation in the person's inner world where the forces of health and the forces of sickness are now almost comparable to each other. And the excess positive capacity necessary to really go into deep catharsis or deep analysis is not there. So it is a stalemate because of opposite forces of health and ill health getting comparable in the unconscious mind. And after some time, as the capacity of the healthy part exceeds that of the sick part, it will be overcome. But there is a stalemate. There can also be a stuckness which appears in the very early part of the therapy. And this may be related to inability of the patient to accept that he has a disorder. So if somebody comes to you with a borderline personality disorder, and the moment you mention it, the person feels you are labeling him and attacking him. So accepting and owning up the problem the person has is shattering for the person. The person is too fragile. So this can also happen that the fragility is so high that the person cannot accept that he has a problem. And it may take a long time before the person is truly able to accept that indeed he has a problem. So he may keep coming to the therapy, but in one part of himself, he'll keep denying that he has a problem. And this would be true for fragile narcissistic patients and those who have psychosis with negative symptoms and regression to the primal narcissism, where the stuckness will be that everything is okay till you touch the core. The stuckness will come the moment you try to touch the core, or it will not come. It's a very variable stuckness. That the moment you try to touch the core, you feel you are in a stuck situation. And more often than not, this category leaves therapy the moment the core is focused upon intensely. So the only way out, which is not a practical way, but still the only way out, is to have a long cohesion therapy, expecting that some life events will add to the person's capacity and someday he will be able to accept the problem and be ready to address it. Without his readiness, if you go forward, it can create a situation where, and this is very true of people with psychotic structure and a neurotic problem, that they come with a neurotic problem with underlying psychotic structure, and the psychoanalysis itself precipitates psychotic symptoms. And I know of people who had to stop therapy because of this. So then they need a different approach, a different school.
Right. So lastly, there are some patients who just don't come after a session, when before the session for months, everything was all right.
Yeah, this is also a very common experience for everyone. And there are certain reasons why they don't come back. Essentially, what we are dealing with is what I call DAM, DAM, destructive affect mobilization.
Okay.
That too quick, too much affect of the unbearable type has been knowingly or unknowingly activated by the therapist. And I always say, damned if you damn. So we have to be very careful that we generate affect in tolerable doses.
Right.
Now, what are the specific events in which this dam can happen?
Mm.
It can be fragility. That the person is hanging from a rope and you are trying to interpret the rope. So it's terrifying for the person for that thing to go. So if nothing is working and person is believing that I believe in God and he will do everything okay, and you are trying to tell him that you are living in fantasy, this fantasy is the only rope by which he is hanging. There is no other rope for him to hang. So that is where we have to be practical and compassionate and more existential and not be book correct. That you don't have to interpret every pathology. Often pathology might be the only rope by which he is hanging, and that hanging may be a less pathological situation than the greater pathology into which he will fall if you take that rope away.
Absolutely.
So maybe the smaller problem is a solution to a bigger problem, and you are trying to solve the smaller problem and is terrified of it. Because his unconscious knows what is in store. His conscious does not know, you also don't know, but his unconscious knows. So the terror comes from the knowledge of his unconscious. Second is invalidation. Third, betrayal. Fourth, disappointment. And fifth, shame. Either of it evoked very strongly, and the person can stop coming all of a sudden. Out of nowhere, the therapy ends. There is a very famous quotation. It says, brilliant interpretation and the therapy ended.
Right, sir. So it was a discussion of great guidance. If you are a therapist and you have questions, feel free to send them to us. See you all again. Namaste.
Namaste.